Chapter 12, Aseptic Technique and Sterile Compounding. We'll skip over the terms and definitions because we will cover them throughout the chapter. Proper preparation of parenteral medications is one of the most crucial responsibilities of the hospital pharmacy technician because these medications enter the bloodstream directly, usually through injection. Preparation of all parenteral medications in a manner that reduces the chance of contamination is important. This is possible only through the proper manipulation of materials used within the appropriate hood. Various sizes and types of hoods are available. All are capable of excluding bacteria and other unwanted particles if the technician uses proper aseptic technique. Aseptic technique involves procedures used to eliminate the possibility of a drug becoming contaminated with microbes or other unwanted particles. The pharmacy technician may prepare compounded sterile preparations, abbreviated as CSPs, in pharmacy settings such as home health services and long-term care facilities. This chapter focuses on the technician working in a hospital pharmacy with the regulations of the United States Pharmacopoeia, Chapter 797 on pharmaceutical compounding sterile preparations are explored, as are policies established by other organizations to monitor compliance in the sterile preparation of compounded products. Wider varieties of parenteral medications are used in the hospital than in any other setting. In the hospital, the pharmacy technician may be responsible for many daily tasks related to compounding sterile preparations. Solutions, medications, and supplies may be required when preparing sterile products. Terms used to identify these items often are abbreviated in prescribers' orders and on supply lists. Pharmacy technicians need to understand these terms and abbreviations to interpret orders and fill stock levels in the intravenous room. Table 12.1 lists some of the most common terms and abbreviations used for IV supplies. So we have AMP for ampule, flexible bag, MDV, multi-dose vial, holds multiple doses of medication. Just going to highlight that. That might be important for you when you're doing your homework or quiz. We have SDV for single dose vial. Then we have our D5NS, 5% dextrose and normal saline. D5, 1/2 normal saline. So that's 5% dextrose and 0.45% normal saline. And then we have normal saline, which is 0.9% sodium chloride. So that's a very important one to know and memorize. And then also this one right here, which is 1/2 normal saline. So if you divide 0.9 in half, you get 0.45%, and that is where that percentage comes from. Anytime you see a 5 or a 10 in between W, that's whatever percent dextrose in water. And the same goes for if you see NS, that's normal saline. So it could be 10, 5, whatever. And then LR can be for lactated ringers or ringers lactate solution, which is just an isotonic solution that contains sodium, potassium, calcium, acetate, and chloride. Another important one in the pharmacy hospital world is SWFI, which stands for sterile water for injection. Then we have our routes of administration for parenteral agents. And then miscellaneous terms used with parenteral medications. When working in a hospital setting, all employees must comply with the policies of standard precautions, also known as universal precautions, to prevent the dissemination of highly contagious diseases Hospitals usually require an employee to receive both tuberculosis testing and an immunization against influenza annually. Standard precautions are practices followed to prevent the transmission of infection and contamination. They are based on the principle that all blood, body fluids, secretions, excretions, non-intact skin, and mucous membranes may contain infectious agents. Based on the anticipated exposure to potential infectious substances, each area in the hospital has specific infection control guidelines, which can be found in the facility's policies and procedures manual. Employees are expected to meet these requirements, including hand washing, orderliness, and cleanliness. The pharmacy does not supply blood or blood products. However, pharmacy personnel must participate in training sessions on bloodborne pathogens so that they not only understand various aspects of contamination, but also are aware of ways to prevent exposure and transmission of infections. For example, training includes the interpretation of room signs that indicate patient isolation and the precautions and procedures that should be allowed if access to these rooms is necessary. Other hospital-wide standards include the following. Employees are not to use patient restrooms. They should only use employee restrooms. Medication refrigerators and freezers may hold only medications. They should not be used to store food or drink. Eating is prohibited in any drug preparation or patient care area. And the following are examples of procedures specific to the pharmacy. All injectable drugs and other compounded sterile preparations must be made in a clean room under laminar flow hoods. All flow hoods are recertified every 6 months by an independent contractor or anytime the hood is moved. Routine maintenance of hoods includes cleaning all surfaces and pre-filters. Records of all inspections are to be kept on file in the pharmacy department. Different types of equipment are available for IV preparation depending on the amount or volumes to be prepared. For instance, many different types of automated pumps automatically fill IV bags and other sterile containers. These pumps range in complexity and cost. For example, if large multi-additive automated machines are rented by the pharmacy, only the tubing required for that specific pump needs to be purchased. Small pumps such as Baxa's repeater pump are used to administer smaller reconstituted volumes into single dose vials or larger volumes into multi-dose vials. In addition, a wide variety of supplies used in the clean room must be kept in stock for daily use. For this reason, the technician must inventory these supplies and reorder stock daily, anticipating the stock needed for the next day. So table 12.2 shows commonly used intravenous room supplies. So 70% isopropyl alcohol, and we use that for an antiseptic for cleaning the hood. So I'm going to highlight that because that's super important. Maybe see that on an upcoming test or quiz. An ampule breaker, filter needles, filter straws, filters, forceps, and many other things. Syringes used in the pharmacy are available in 8 basic sizes. That is 0.5, 1, 3, 5, 10, 20, 30, and 60 ml. As the size of the syringe increases, the accuracy decreases. So that's super important to remember there. For parenteral products, the exact amount of drug ordered must be obtained. Syringe tips are available in 2 types. A tension type syringe has a 1 ml volume. In this case, the needle is attached by friction only. This type of syringe can be used for withdrawing insulin and other medications that require volumes of 1 ml or less. However, tension type tips cannot be used when preparing doses of chemotherapeutic drugs because of the risk for the needle detaching from the syringe and causing a spill or a possible needle stick to the technician. On all other sizes of syringes, the needle is held in place by a locking mechanism commonly referred to as a Luer lock. This ensures a safe seal for withdrawal of the medication. Figure 12.1 is the anatomy of a syringe. As the syringe decreases in size, the calibrations, the volume markers, become larger, allowing a more accurate dosage. And you can see all the different parts, the flange, the plunger, the tip, points of measurements, the barrel. Figure 12.2 shows our two types of syringes. A is a regular type syringe. This regular tip is held in place by pressure as seen in the 1 ml syringe. And B is the Luer lock. You can see the little screw there. It has spirals to secure the needle as seen on a larger 3 ml syringe. Most syringes are made of plastic and must be discarded after one use. Glass syringes rarely are used in the pharmacy, although they can be used when a patient is allergic to plastic. Glass syringes, unlike plastic syringes, can be sterilized and reused. Another type of syringe is a Tubix or Carpuject. That's right here. These cartridge systems can hold a variety of medications and are available in volumes from 0.5 ml up to 3 ml. The bottom of the cartridge is screwed into the system syringe holder. The syringe cartridge holder for these systems are reusable and normally are dispensed to the nursing units by the pharmacy on request. The Tubix or Carpuject cartridge is discarded after use. If desired, the holders may be autoclaved for sterility. Needles are made of aluminum or stainless steel and are available in many different gauges, sizes, and lengths. Higher gauge needles, like 20 to 25 gauge, are used by nurses to administer injections. The nurse determines which gauge and needle length to use according to the injection site. In the pharmacy, needles are used to draw solutions into a syringe, not to administer medications to patients. A limited number of needle gauges are available in the pharmacy, and the lower gauge needles make drawing medications easier. The most common needle size used for preparing IV medications are 19, 18, and 16 gauge, which are used to draw solutions from vials or other containers. These needles are normally 1 to 1.5 inches long. The gauge number of a needle is inversely proportional to the bore, which is the opening size of the needle. This means that as the bore size increases, the gauge decreases. For example, a 25 gauge needle has a much smaller opening than a 19 gauge needle. The bore size refers to the circumference of the needle opening, and as this increases, so does the probability of coring or cutting out a piece of rubber from the vial's rubber stopper. When a vial is cored, a chunk of rubber is dislodged and may fall into the vial. To avoid coring, the bevel edge should face upward. If coring does occur, a filter needle must be used to prevent the piece of cored rubber from entering the parenteral solution. No part of a needle below the hub should be touched. The point and shaft must remain sterile. So figure 12.4, we have the needle sizes from left to right. So 19, 20, 21, 23, and 25. Technicians may use a 19 gauge needle for small volumes, such as 1 ml or less. Larger gauges that are not shown include 18 and 16 for larger volumes. And then we have the anatomy of a needle. We have the point, the lumen, which is this little part here in the opening, the bevel, shaft, hilt, and then the hub, which is where that screws into the Luer lock. Different types and sizes of filters can be used When preparing parenteral medications, filters are located within the hub of the needle depending on the type used. Typical filter sizes are 10, 5, 1, and 0.45 micrometer. The smallest filter is 0.22 micrometer, which removes all unwanted particles from the solution. If use of a filter needle is necessary, the technician must follow the manufacturer's guidelines regarding filter needles suggested for the specific medication. Some medications should never be filtered because filtering would remove active drug from the solution. Filter needles are for single direction use only and cannot be used to both withdraw and inject a solution. Another type of filter is the filter straw. The straw-like needle can withdraw a larger amount of solution quickly, sifting it through a filter in the hub of the needle. The filter straw often is used to remove any fine particles of glass from an ampule. The filter straw must be replaced with a normal needle before the medication is pushed into the final container. So we have different types of, we have A, which is mini spikes used in multi-dose vials, B, filter needles, C, filter sizes, D, ampules and ampule breakers, E, we have transfer needles, and F, we have syringes and caps. All the items located in the IV room of the pharmacy must be kept in stock above their minimum levels at all times. Current USP 797 standards require that a minimum number of supply items be kept in the clean room. Only items that will be used immediately for direct compounding should be in the clean room. Supply items must be wiped down with an appropriate cleaning solution before they are brought into the clean room. Before and after each shift, the IV tech is responsible for reordering and restocking the clean room for the next shift. Some IV supplies may be ordered from the central supply area of the hospital and arrive by the next shift. However, most supplies are ordered directly from the pharmacy wholesaler and delivery can take 2 days to 1 week. Therefore, to ensure that required pharmacy stock is always on hand, the technician should be knowledgeable about delivery options. Many IV antibiotics are available in pre-made bulk packs. For example, 12 or 24 packs are frozen in boxes. Although these are convenient, they are more expensive than those prepared by technicians. Most of the time, technicians prepare the IVs needed throughout the week. Certain IV medications can be frozen in either IV solutions or syringes, but each bag must be marked with the date of reconstitution, the beyond use date, the concentration and strength, and the preparer's initials. The expiration dates for frozen, refrigerated, or room temperature products are determined by using the manufacturer's information, the known stability data, and other pharmaceutical specialty publications and research. Large temperature controlled refrigerators may be used to store thawed IV medications. Antibiotics and other medications and MDVs can be stored in the refrigerator after opening, sometimes for days, and used as determined by USP guidelines for MDVs. All of these items should be visually checked each day for stock levels and out-of-date medications. Because prepared solutions differ in their volumes and/or concentrations, understanding the routes of administration is important. For example, if a dose of ceftriaxone 1 gram is to be given intramuscularly, it is normally divided into 2 syringes for the nurse to inject into each side of the hip area. Injections can be given on several areas of the body. The route of administration of each medication must be on the label. Many different types of containers are used to deliver medications. Advanced technology includes smart pumps, which contain databases of drug information, concentration, and dosing units and limits. There are also special containers developed to be stable and easy to use. In addition, because many medications are not pre-made for final use by the manufacturer and they must be prepared in the pharmacy, It is important to determine whether the medication must be discarded if not administered to a patient in a timely manner. For example, once a medication has been reconstituted, it must be used within a certain time or it expires, resulting in lost revenue for the pharmacy. Sometimes the drug may not be given to the patient from whom it was prepared. The physician may have decided to use a medication of a different dose type, volume, and solution. This type of waste only adds to the high cost of healthcare. Systems can be used to eliminate waste, such as the Advantage system. Although these systems are expensive, they can be beneficial by reducing waste and ultimately adding cost efficiency. Flexible bags and bottles are the two main types of piggyback containers. Most IV bags are made of polyvinyl chloride, which consist of several flexible layers of plastics. Other types of IV bags are made with non-PVC materials such as ethylene vinyl acetate. The EVA bags are not as flexible as PVC bags. Piggyback IVs are intended to be placed on top of a primary IV using tubing connection sets. Containers can be purchased pre-filled with solutions or may be empty and filled with a custom-made IV solution. The sizes and types of piggyback containers and solutions range from 50 to 250 ml. Examples of specialized containers used for medication dispensing include large and small volume drips, syringe pumps, and miscellaneous dispensing systems. Many controlled substances also are prepared in such systems and are dispensed to the nursing floor after they have been documented according to established procedures for controlled substances. So figure 12.7 shows the gravity pump system intravenous piggyback setup with a 100 ml ViaFlex container piggyback to a large volume IV, 1 liter IV line. Large volume drips include ViaFlex bags in 500 ml and 1, 2, and 3 liter volumes. Volumes greater than 1 liter are often reserved for use with parenteral nutritional formulas. Bottles are also available in various sizes ranging from 500 ml to 1 liter. These can deliver a variety of fluids, including parenteral nutrition. Parenteral nutrition is a combination of essential nutrients that is administered through a drip system for several hours or up to 24 hours. Parenteral nutrition solutions are discussed later in this chapter. Small volume piggyback containers and solutions are available in 50, 100, 150, and 250 ml volumes. Small volume drips can be piggybacked onto large volume drips. All ViaFlex bags have a 10% overfill of solution. To attain an accurate final concentration of a drug, some mixtures require that a volume of base solution equal to the volume of medication being added, plus the solution overfill, be removed during the mixing process. This type of procedure usually occurs with critical care medication drips, in which small changes in drug concentration may greatly influence the dosage given to the patient and the subsequent patient response. Patients who require analgesics after major surgery and individuals who are in hospice normally have their medications prepared in the pharmacy. In the hospital setting, nursing stations stock various drinks of controlled substances intended to relieve extreme pain. Depending on the physician's order, the nurse can prepare IM or IV push doses from the controlled substances cabinet. When a patient is in severe pain, physicians often order analgesic medications such as morphine or fentanyl, which are both Schedule II drugs, on a schedule, like every 6 or 8 hours. When this strength of analgesic is given in larger doses to patients who have no history of opiate use, the initial effects of the medication may be extreme, causing side effects such as nausea, vomiting, and in some cases, difficulty breathing. Toward the end of the 6 or 8 hours, some patients are once again experiencing pain and waiting for the next dose to be administered. To provide a more constant degree of comfort and to limit unwanted side effects, some patients may be given either an implantable pore or catheter system attached to a portable electronic pump system that administers a steady flow of analgesic to control the patient's pain more effectively. These pumps are used to dispense controlled substances at a specific rate of infusion. Two types of portable electronic pumps can be used to deliver controlled substances, a syringe system or a cassette system. Technicians may prepare either syringes or cassettes that are placed into a pump that automatically deliver the medication over a predetermined time. These pumps can be programmed for short or long durations to deliver medication not to exceed a 24-hour period. These devices are especially effective for patients who require constant pain control and those discharged home with this type of medication. Another type of dispensing system that uses syringes relies on gravity for delivering the solution. The syringes are placed in a freestanding IV pump system on wheels. These are used only in the hospital. Patient-controlled analgesia is a method of administration that allows the patient to control the rate at which the drug is delivered for the relief of pain. The PCA pump holds a syringe of pain medication that is attached to the IV line and is regulated by a computerized device that automatically dispenses the medication. The pump may be programmed to deliver a small, constant dose of pain medication, and the patient has the option of receiving additional doses, a bolus, if necessary. This is done by depressing a medication attached to a line on the machine. The boluses are present for amount and frequency. Even if the patient presses the button many times, he or she receives only the predetermined amount of drug. For example, if the dose is set at 1 milligram per ml with dosing intervals every 6 minutes and a 1 hour lockout dose of 10 milligrams, regardless of how many times the patient presses the button within 6 minutes, he or she only receives one dose. The 1 hour lockout limits medication administered to a total dose of 10 milligrams in 1 hour. This safeguards the patient from overdosing. The PCA syringe device is normally used in a hospital setting for acute post-operative pain control. Children ages 7 years and older can typically use this pump device independently once they're familiar with it. Young or debilitated patients need assistance from a nurse or caregiver to receive their dosing. Many manufacturers provide pre-filled PCA syringes that may be used directly from the packaging in these pumps. Alternately, pharmacy technicians can prepare the syringes for PCA pumps. Each syringe must be labeled, capped, and checked by the pharmacist before delivery. When the pharmacy technician is ready to have a prepared medication expected by the pharmacist, he or she should include the finished product along with the syringe, the opioid analgesic container, and the diluent used in its preparation. The following are some manufacturers of PCA syringe systems. So we have Atex, B. Braun, and Smith's Medical Medfusion. Cassette pumps are another type of PCA system that can be used at home. Program pumps work similarly to the syringe pumps in that they are preset for dosage administration. Additional boluses may be programmed into the pump per the physician's orders and cannot be altered by the patient. A bolus is a predetermined amount of drug that can be administered by the patient at one time when pain intensifies. The cassettes are available in various sizes, such as 50 or 100 ml volumes. The pharmacy may prepare the cassettes. A short piece of tubing with a luer lock can be connected to a 60 ml syringe that is used to load the proper amount of solution. After the cassette has been filled, the line tubing must be primed. To prime a line, the tubing is allowed to fill with solution so that there is no air in the tubing. The tubing then is secured with a twist cap. This is usually done by the pharmacy at the time the medication is prepared. So 12.8 figure, it shows the patient-controlled analgesia device with cartridge. And the following are examples of these PCA cassette systems, CAD pumps. and ambient infusion pumps for home use. The USP, the United States Pharmacopoeia, is responsible for providing safety guidelines for the preparation of parenteral and other sterile medications. In the 1970s, because of the dramatic increase in known scomial infections, the National Coordinating Committee on Large Volume Parentals provided guidelines for the preparation of parenteral medications. A non-scomial infection or a healthcare associated infection is an infection that originates in a hospital. Later in the 1980s, the efforts of the NCCLVP were replaced by several other organizations that began to establish standards for pharmacists and technicians in the safe preparations of parenteral medication. These organizations include the ASHP, the National Association of Boards of Pharmacy, and the United States Pharmacopoeial Convention. Through the 1990s, these organizations wrote both recommendations and guidelines for safe standards, but they were not monitored or enforced. In the mid 1990s, it was determined through health system surveys that very few pharmacies actually followed these standards explicitly. For example, most pharmacies did not perform quality assurance checks or solution tests on a regular basis for prepared parenteral medications, and many did not provide training and education for personnel on a periodic basis. In addition, various IV medications were reported contaminated with bacteria because of poor aseptic technique. The reports of patient harm from improper preparation of medications by pharmacies continued through the 1990s. In 2004, the USP 797 regulations were written with the intent that they would constitute an enforceable standard. The USP 797 standards must be met in all practice settings where sterile products are compounded. The USP, ASHP, and the Joint Commission outlined a timeline for total compliance, realizing that it would take time for pharmacies to implement all the changes mandated. Pharmacies and other areas that prepare compounded sterile preparations must research, create, and document their standard operating procedures for meeting USP 797 regulations. In June of 2019, the USP 797 released the current version for industry effective December 2019. A number of changes were made, including clarification regarding the use of alternate technologies when preparing a compounded sterile product. A comprehensive list of definitions, including the terms used in this chapter, was provided. The risk categories of CSPs were revised with two instead of three based on conditions under which they were made and the time period in which they would be used. Just highlighting that might be really important to you. More information on the revisions can be found at the USP website. In 2013, as a result of the fungal meningitis tragedy at the New England Compounding Center, a group of executives from the sterile compounding industry formed the Specialty Sterile Pharmaceutical Society. It, it was founded to support more stringent standards of practice regarding quality control and to ensure the safety and welfare of individuals receiving CSP. Table 12.3 shows the environmental cleaning schedule with the site and the minimum frequency. So that's an important table there. Sections of the United States Pharmacopoeia 797, it has the following major sections. 1, scope, the list of sterile compounds, specific practices, and risk factors. 2, personnel qualifications, proficiencies, training, and evaluation. 3, personal hygiene and personal protective equipment, hand hygiene and garbing. 4, building and facilities, facility design and environmental controls. 5, environmental monitoring, the air quality and surface sampling procedures. 6, cleaning and disinfecting surfaces, tools used. 7, equipment and component packaging, ingredients. 8, sterile and diprogenation, process for sterilizing and filtering of CSPs. 9, standard operating procedures and master formula records and compounding records. Documentation explained. 10, release testing, final product inspection processes. 11, labeling required information for CSPs. 12, establishing beyond use dates and in use times, methods for establishing BUDs. 13, quality assurance and quality control, programs and documentation required for compounding pharmacies. 14, compounded sterile preparations, storage, packaging, and transport, proper methods for CSP handling. And 15, documentation requirements per USP for compounding facilities. 12.4 is terms and abbreviations used in the pharmacy related to 797 standards. So we have the ante-area, an area in which all preparations for intravenous admixture are gathered, including labels, gowning, and drug materials. Beyond use date, the date or time a drug or material can be no longer used. The drug is ineffective after this date. The biological safety cabinet, a cabinet with high efficiency particulate air, HEPA filter for laminar airflow. The buffer area, an area in which hoods are kept and IV preparation takes place. The clean room, a space where microbial containment is kept at a specific level of safety to ensure a certain level of cleanliness. The compounding aseptic isolator, an isolator cabinet designed to contain all contaminants. It prevents contaminants from escaping IV lines and being transferred to the surrounding area. The critical site, an area exposed to air touch, such as a vial, a needle, or an ampule. The direct compounding area, a critical area within the hood where compounding materials are exposed to filtered air. This is also known as first air. First air, the air from the HEPA filter that passes over material. This air is contaminant free. Hazardous drugs, drugs that have been proven to have dangerous effects during animal or human testing. They may cause cancer or harm to certain organs or to pregnant women. Media fill test, a test performed on compounded products to ensure that no contamination has taken place during preparation phase. A multi-dose container, a vial or container that can be used for more than one admixture. The negative pressure room, a room that has lower pressure than the adjacent rooms. Net airflow is into the room. The positive pressure room, a room that has a higher pressure than the adjacent rooms. Net airflow is out of the room. The primary engineering control, a practice in which an ISO Class 5 system is in place that provides safety for admixtures. This includes laminar flow hood, glove box, vertical flow hoods, or compounding aseptic isolators. And then finally, single dose containers, a vial or container that can only be used once. The USP 797 has identified 2 risk levels, which are based on various criteria per USP. Category 1 CSPs are those assigned a maximum BUD of 12 hours or less at controlled room temperature or 24 hours or less and must be compounded in an international organization for standardization, Class 5 environment. Technicians must wear gown, gloves, hair covering, and mask during manipulation. These items of clothing are typically referred to as personal protective equipment or PPE and must be provided by the facility. The technician must verify all ingredients and instructions and visually inspect the solution after preparation. Each person's knowledge of aseptic technique and proper manipulations must be monitored and verified quarterly. In addition, a quarterly media fill test must be done for each person compounding products in the hood. Environmental compliance, such as surface sampling and proper testing and certification of environment and equipment, also must be performed. Category 2 CSPs are those that have a BUD of greater than 12 hours at room temperature or greater than 24 hours if refrigerated. These CSPs also must meet the same garbing and environmental controls as Category 1 CSPs. In addition to the two categories, there is an urgent use CSP defined. This compounding would take place in emergency situations such as cardiopulmonary resuscitation. In this situation, the compounding process can take no longer than 1 hour, and administration of the CSP should be immediately after the completion. Aseptic technique should still be followed and procedures kept in place to minimize potential contamination. All personnel who prepare parental medications are required to be trained and monitored for compliance with techniques on a periodic basis. This includes ensuring that the drug ingredients, containers, labeling, and equipment are correct. Products must be stored according to manufacturer guidelines or other scientific findings. In addition, pharmacists must determine the risk level of each type of preparation. Although USP 797 outlines risks, the standards do not rate every type of manipulation. The standards outline basic guidelines. The hoods and clean room, in addition to the pharmacy rooms adjacent to these rooms, must be within the USP guidelines of USP 797, and it is essential that any contamination be kept away from these areas. The guidelines for standard air standards in IV areas and individual hoods are listed below here. So you can see the United States Pharmacopoeia 797 air standards based on 0.5 micrometer particle size. Most pharmacies can easily meet educational and training aspects of 797. However, this is not true of the new regulations related to the areas where these products are prepared. Each type of environment in the pharmacy is required to meet minimum standards pertaining to airflow, microbe, and particle size and quantity. According to studies conducted by USP, using a laminar airflow workbench in an open room is no safer than preparing products on a countertop. This has been one of the most significant changes in pharmacy. As a result of the enormous expense required to create these new areas, many hospitals now contract out to specialized pharmacies to prepare their compounded sterile preparations. Facilities that have been able to meet USP standards must also test the air periodically to ensure that guidelines are met. All right, and in box 12.1, we have the environment terminology. So airlock is a space of separation between two different air pressures. Air pressure can be either positive or negative. Positive air pressure environments may be used only for non-hazardous sterile preparation, and negative air pressure environments can be used to prepare both non-hazardous and hazardous sterile preparations. The anteroom, which is a space adjacent to the cleaner buffer room. The biological safety cabinet, a hood that should be used for hazardous sterile preparation in the clean room. The clean or buffer room, the space adjacent to the primary engineering control room where sterile preparation takes place. Compounded septic containment isolator, another type of class 3 CAI glove box that exhausts 100% of the air through a high efficiency particulate air filter. It's to be used for preparation of hazardous medication, and it may also have negative or positive air pressure. The compounding aseptic isolator, a class 3 glove box that can have either negative or positive air pressure. And then the laminar airflow workbench, a hood that should be used for non-hazardous sterile preparation in the clean room. And then we have the primary engineering control, which is a space or hood where sterile preparation takes place. The anteroom is adjacent to the buffer room or clean room, just mentioned a minute ago. It's sometimes called the gowning and the degowning area. All donning of PPE occurs in the anteroom. The clean room, where the technician actually prepares compounded sterile preparations, must meet more stringent requirements for air particulate size. USP 797 also requires specific types of hoods to be used for compounding specific sterile products. Laminar flow workbenches that have only positive horizontal airflow may be used to prepare non-hazardous sterile compounds, whereas a negative vertical airflow environment may be used to prepare hazardous products per USP guidelines. A biological safety cabinet is a totally enclosed environment that is available with either positive or negative airflow. These cabinets are known as glove boxes or barrier isolator hoods. All types of hoods have high efficiency particulate air HEPA filters, although the way in which they expel the air differs. Proper use of these hoods requires additional training. The hoods must be verified and certified every 6 months or whenever moved to ensure their ability to filter contaminants. Both anterooms and clean rooms must be within standards. Assessments must be completed by a certified outside source, and any movement of the equipment requires additional inspection. Pharmacies must use special equipment and chemicals to sterilize the anteroom and clean room. Specialty knowledge about the proper way to clean each room is also required. For example, hoods and surface areas must be cleaned and sterilized daily, and the walls and floors must be cleaned and sterilized weekly. SOPs must be written and studied, and all who work in these areas must take evaluation examinations. Three types of hoods are used depending on the sterile product being prepared. The horizontal flow hood, such as LAFW, the vertical laminar flow hood, such as BSC or compounding aseptic containment isolator, and the isolator hood, which is also referred to as a glove box. LAFWs are used for many types of parenteral or sterile product preparation. Horizontal hoods provide positive air pressure, moving the filtered air outward toward the preparer. For chemotherapeutic agents, a type of vertical flow hood known as a BSC or CACI is used because of the direction of the airflow and the specifications of the hood. A vertical flow hood provides negative air pressure, circulating the air through an additional HEPA filter and then through a vent away from the preparer. Another version of a vertical flow hood can be used to mix non-chemotherapeutic agents if needed, such as non-sterile compounds. However, hazardous drugs such as chemotherapeutic agents should never be mixed in a LAFW or any type of horizontal flow hood. Isolator hoods, also known as glove boxes, are closed systems that use a HEPA filter and a sophisticated venting system. These provide the greatest amount of safety to the preparer because of the containment ability. With all systems, strict aseptic technique and care must be used because spillage can still occur on the surface of the IV bag or container and can cause contamination or unwanted exposure on removal from the hood. In a horizontal flow hood, laminar airflow workbench, the outside airflow starts in the back of the hood, passes through a special filter, and circulates outward the opening across the deck or direct compounding area. This special filter is a HEPA filter that traps particles larger than zero point 0.2 micrometers. The sides of the hood and items within the hood create a disruption of airflow. For this reason, the technician must work at least 6 inches from the sides and front of the hood. In addition, movement within the hood should be kept to a minimum to reduce disruption of airflow. So you can see here that the items in the hood must be 6 inches apart and 6 inches from the side in front of the hood. The concept is similar for a vertical flow hood, although air cannot be released back into the room. For this reason, vertical hoods have a plexiglass shield that separates the technician from the inside work surface. In a vertical flow hood, such as a BSC or a CACI for compounding a hazardous drug, air enters the HEPA filter vertically, flows down, passing into the HEPA filter, and then on to the workspace area. A grid at the front of the tabletop draws in the air and filters it once again with a HEPA filter before it is released into the workspace area or is vented to the outside, depending on the type of venting system used. Regardless of vertical or horizontal hood airflow, the technician must not block the flow of air while working. Air This air is considered first air and it must remain free of obstruction to ensure the critical areas are free of microbes. It is best practice to leave primary engineering controls turned on at all times, but if this cannot be accomplished, a LAFW must be turned on at least 30 minutes before use. Every 30 minutes while in continuous use, when there are spills or when there is a suspected contamination. In addition, daily cleaning is required and is best performed at the end of the day. The cleaning must be performed by trained compounding personnel, not environmental departments or outside sources. As mentioned, there is also a PEC known as a glove box or barrier isolator. It is becoming the most popular type of hood for sterile preparation. It reduces the risk for contamination caused by accidental mishandling of drugs during compounding and reduces the number of environmental microbial contaminants, thus increasing the sterility of the prepared product. This ultimately protects patients from possibly harmful medications. If it is a BSC, it also protects the person preparing a hazardous or chemotherapeutic agent because these medications can be harmful if they are inhaled or come in contact with the skin. The air is redirected through a HEPA filter, and an additional airflow system helps decontaminate the medication preparation. Daily monitoring of the pressure gauge flow indicators or alarms should be documented. A BSC must be turned on at least 10 minutes before use. After the technician washes his or her hands and cleans the hood properly, all the necessary materials and medications can be placed inside a sterile holding chamber. Using the attached gloves, the technician takes the materials from the sterile chamber and transfers them into the main hood. All products and supplies should be placed at least 4 inches inside the sash. At this point, the technician may prepare the medication. Any high risk medication can be prepared in this type of hood. Inspection should be performed every 6 months in an effort to comply with USP 797 guidelines. More pharmacies are using these types of hoods. All hoods in the pharmacy must be thoroughly cleaned using the appropriate solvent and cleaning methods. Procedure 12.1 lists systemic instructions for cleaning a laminar airflow workbench and lists the instructions for cleaning a vertical flow hood. Cleaning of BSCs differs from the cleaning of horizontal and vertical flow hoods as described in procedure 12.3. So we have procedure 12.1 on cleaning a horizontal laminar airflow hood. So you can look through that and read through all those directions. And then procedure 12.2 shows cleaning a vertical airflow hood. Procedure 12.3 shows cleaning a biological safety cabinet. When CSPs are prepared, aseptic techniques must be used. Normally, nurses do not have the advantage of using a laminar flow hood. However, they sometimes must prepare products for immediate use and they still must use strict aseptic technique. Aseptic technique is directly associated with universal precautions. Universal precautions are guidelines followed by all healthcare workers when exposure to body fluids or blood products is likely. These precautions involve washing hands and putting on gloves and gowns when in the presence of any body fluids. Similarly, aseptic technique is used when both hazardous and non hazardous products are prepared. Products that have been tested and shown to cause adverse or toxic effects in humans are classified as hazardous. Examples of these types of medications include chemotherapeutic agents, radioactive compounds, and various hazardous chemicals such as phenol and glacial acetic acid. These precautions are used to prevent contamination by a product or to a product. For pharmacy technicians, the importance of using aseptic technique cannot be stressed enough. Do not touch your face or glasses with sterile gloves because touch contamination is the most common way to introduce microbes to a CSP. A medication that contains any microbes or unwanted debris can cause a dangerous infection or even death when administered to a patient. The steps used in aseptic technique begin with hand hygiene, followed by proper donning of gloves and gown, cleaning of the flow hood, and finally, preparation of the parenteral medication. Procedure 12.5 lists the preparation required for aseptic technique, except for putting on the surgical face mask immediately before entering the hood. All these steps should be completed outside the clean room. On leaving the IV room, the technician must remove the hair cover, gloves, and face mask. Another consideration is the preparation of the rooms and equipment used in preparing CSPs. Accuracy in performing calculations and measuring medications is paramount. All calculations and measurements should be double checked and must be verified by pharmacists. And then figure 12.13 shows the technician prepares supplies and medications staging and the pharmacist approves. Procedure 12.4 is on proper hand hygiene. Procedure 12.5 is on personal cleansing and garbing order. Regardless of the type of hood used, the placement of the hands is one of the most important aspects to consider when preparing sterile products. The technicians should practice some simple yet important techniques that reduce the possibility of contamination and errors when preparing CSPs to avoid compromising first air. Figure 12.15 outlines the necessary steps for withdrawing a liquid from a vial while working in the hood. When working in a horizontal hood, you must not block the airflow or contaminate a critical site or any area at any time. To prevent this, grasp the vial or ampule by the front. Avoid placing the hand or fingers right behind the top of the container. When holding up the vial or ampule, keep the fingers from blocking airflow. This technique takes time to perfect and should be practiced constantly until it becomes second nature. When working in a vertical flow hood, avoid placing the hands and fingers over the container because this would break airflow. It is also important not to overload the hood with drugs and supplies, which can lead to a break in aseptic technique and increases the likelihood of drug errors. When using a BSC, you must follow strict protocol in handling and transferring solutions. So here's figure 12.15 as I mentioned above. This is the process for drawing medication from a vial. So after using the sterile 70% alcohol wipe, you're going to wipe the top of the vial and place the needle bevel side up and push it into the rubber stopper of the vial. You're going to preload the syringe with a necessary amount of air to replace solution. Invert the vial and syringe 180 degrees and push in the air from the syringe and pull out of the solution. IV push or IM medications can be prepared by the nurse at the nursing station or at the patient's bedside. However, the pharmacy does prepare some IV push and IM medications. These agents are placed in a syringe and sealed with a syringe cap until it is time to administer the medication. Technicians must follow the steps outlined in the following sections and shown in figure 12.16 when preparing these syringes from ampules. The procedures differ from for those followed when using a vial. Once the medication is withdrawn, replace the filter needle or straw used with a regular needle and inject the drug into the IV solution. However, if the drug is to be transported in the syringe, remove the needle and cap the end of the syringe. Label the container and place it in the proper location for the pharmacist's inspection. When solution is pulled from an ampule, there is no positive or negative pressure because this is an open system. That is, the container is open and able to allow air to enter it, replacing the missing volume of solution. However, it is important to remember to use a filter needle when transferring drug from an ampule because small pieces of the ampule may detach and fall into the solution when the ampule is broken. A filter needle may be used only for one draw. Either it can be replaced by a regular needle before the drug is pushed into a piggyback, or a regular needle can be used to withdraw the solution, and then a filter needle can be used to push the filtered solution into the piggyback. Otherwise, the glass trapped in the filter needle is pushed into the final solution. The two types of vials are those intended for immediate use, single dose vials, and those that can be used more than once, multiple dose vials. I'm just going to highlight this. You might see this on one of your tests or quizzes. Because they're not discarded after one use, MDVs contain preservatives. Volumes for SDVs and MDVs range from 1 ml up to 100 ml, and vials may contain either solution for withdrawal or powder for reconstitution. When an MDV solution is used, the date the vial was opened must be written on the label, along with the initials of the person who opened the vial. Re- Reconstituting a medication is the addition of a diluent, such as sterile water, to convert the medication into solution form. If an antibiotic MDV portion has been used, the following information must be indicated on the vial: the date the vial was open, the date the vial expires, the diluent used, the concentration, and the technician's initials. Bulk vials can be reconstituted in varying concentrations per the manufacturer's instructions to provide multiple IV bags for future use. For example, a cefazolin 10-gram bulk vial can be reconstituted with 45 ml of sterile water, which provides a final concentration of 1 gram per 5 ml. This supplies 10 1-gram bags of cefazolin that can be used immediately or can be refrigerated or frozen for later use. BUDs differ between frozen and refrigerated medications. Many antibiotics are available in bulk containers. Specialized types of vials, such as the Advantage system, can be placed on a small piggyback solution with an adapter. These are not mixed with the solution until immediately before administration. The pharmacy technician is responsible for proper attachment of the vial to the proper solution, but the nurse is responsible for breaking the adapter seal between the vial and the piggyback and mixing the powdered drug with the solution. Because the medication does not mix with the solution until the seal is broken, the IV can be returned to the pharmacy if it is not used. This greatly reduces the amount of wasted medication. And figure 1217 shows the Advantage system. A controlled release infusion system is another type of delivery system in which the vial is reconstituted but is not added to the piggyback. At the time of administration, the vial is attached to a special port on the side of the tubing set that allows the medication to enter the piggyback, from which it then is delivered through the IV tubing. Manufacturers have suggested guidelines for dosing regimens and volumes of solutions that most physicians follow. Pharmacies have a chart that instructs the person preparing the medication as to the type and amount of diluent needed, the normal dosing times, and expiration dates. Antibiotics also differ in how they should be prepared and how long it takes the powder to dissolve in the diluent. Once the drug has been reconstituted, the solution should be checked for color and clarity. So table 12.6 shows examples of suggested dosing time solutions and appropriate volumes for antibiotics. So we have the generic name, the brand name, the common dosing regimens, and then the common solutions that are used, and then the common volumes. When a diluent is added to a powder, an equal amount of air must be removed from the vial or positive pressure is created, which causes pressure resistance in the syringe. For example, if you are adding 10 ml of diluent into a powder, push on the syringe until you feel a very slight resistance, and then stop and withdraw an equal amount of air from the vial to relieve the positive pressure. Repeat this until all the diluent has been added. To work with negative pressure, first withdraw air from the vial until you feel resistance, and then allow the vial to pull diluent out of the syringe. Never let go of a syringe. This type of technique works well because there is a less chance of spill. Hyperalimentation or parenteral feeding is a term for large volumes of parenteral nutrition solution, normally prepared for individuals who cannot orally consume nutrition. So this is people with like cancer or that have had strokes, stuff like that. Some reasons for the inability to eat also can be from recent stomach or intestinal surgery, unconsciousness. Of course, if you're unconscious, you can't eat, but you still need nutrition in your body. Various conditions that may adversely affect the gastrointestinal system. Two main types of hyperalimentation are prepared in the pharmacy: total parenteral nutrition, TPN, and peripheral parenteral nutrition, PPN. A peripheral parenteral injection is administered into the veins on the periphery of the body, the arms, hands, or feet, instead of into a central vein or artery. In a hospital setting, after the initial TPN has been prepared and hung, daily laboratory tests of electrolyte levels are drawn from the patient to determine necessary changes. For example, if a patient's potassium levels begin to drop, the next TPN is altered to compensate for this decrease. In this way, the patient receives exactly the nutrients needed each day. Home health clinics and some hospitals prepare hyperalimentation solutions that last 1 week. If this is done, the vitamin additive must be added daily to the TPN because this is one limiting factor for the bag's 24-hour expiration. Electrolyte levels are tested weekly instead of daily. Some patients may receive this type of nutrition for many months. Figure 12.18 shows a TPN preparation connected to an automatic infusion pump system. Many different protocols are used to prepare parenteral nutrition. The following is a list of typical solutions prepared in a hospital pharmacy. The large volume components, protein, carbohydrates, and fats, are pre-mixed and ordered in cases from the manufacturer. Adding to these solutions are the various electrolytes and other compatible medication requested by the patient's attending physician. TPN normally contains 50% dextrose, 10% amino acids, and 20% fat. TPN normally contains 25% dextrose, 10% amino acids, and 10% fat. TPNs are prepared for neonates, children, and adults. Because of the regulations established by USP 797, many pharmacies contract out their TPN PPN orders to specialized compounding companies. Bags can range in volumes from 50 ml for neonates up to 3 liters for adults. It is important to note that neonatal and pediatric additives differ in concentration from adult formulas. Therefore, great care must be taken when pulling the correct medication for preparation if your facility prepares these products. Because of their range of concentrations, PPN solutions are administered differently from the higher concentration TPN solutions. TPN is administered intravenously by the subclavian vein and superior vena cava because of the higher concentration of nutrients. Patients must have a catheter surgically inserted for this procedure. TPN is administered via a peripheral vein, either in the back of the hand or in another peripheral area in the upper extremity, and therefore is a less complicated procedure. Most facilities have a standard order to initiate patient hyperalimentation. The volume of hyperalimentation typically ranges from 2 to 3 liters. The physician determines the rate of infusion over the course of 24 hours. Regardless of how many milliliters run per hour, the hyperalimentation must be changed at least every 24 hours to ensure the sterility of the solution. If if standard rate of infusion is 100 milliliter per hour, then 2400 ml may be used over the course of a day. Most hyperalimentation preparations are tailor-made for each patient. Figure 1219 gives an example of a protocol order. All TPM preparations contain dextrose and amino acids. Both ingredients help nourish the body. The metabolism of dextrose to sugar provides calories and a quick energy source for the body, whereas amino acids are the essential components the body uses to synthesize protein, needed enzymes, and other important molecules. Lipids commonly are added to give the body the fat needed for synthesis of important cell components such as cell membranes. The rest of the additives are additional electrolytes. These components can be determined daily if the patient is in a hospital. Other medications, such as cimetidine or famotidine, both histamine 2 antagonists, which help patients with stomach problems, can also be added to the hyperalimentation. Because besides stomach medications, insulin often is added in quantities up to 100 units per bag. Only regular insulin is added to hyperalimentation preparations because it is the only insulin product that may be given intravenously. Table 12.7 shows the types of parenteral additives. So we have the abbreviation, the meaning, the concentrations, and then some notes here, and then miscellaneous additives and other non-supplements added to TPN or PPN solutions. Many different types of medications are prepared in a clean room. Some medications must be protected from light, whereas others must be kept in bottles. Table 12.18 presents additional considerations in the preparation of parenteral drugs. Special instructions for the preparation of many types of parenteral medications can be found in reference books and IV rooms. The IV technician must become familiar with the idiosyncrasies of medications to ensure that all solutions he or she makes are effective and safe. Table 12.18 is where it shows additional considerations for the preparation of drugs. So the medication amiodarone should only be used with D5W. Ciprofloxacin should be protected from light. Insulin should be only in normal saline or half normal saline. It must be placed in a glass container. Lorazepam is needs to be protected from light. It's stable longer in glass than in plastic. And nitroglycerin D5NS or NS must be placed in glass container. The final step in preparing parental medications is the application of the label. First, check the label against the medication and the physician's orders to ensure that the right medication is being given to the right patient. Although each pharmacy prepares its own label, all labels require the same minimum information. So you can see the intravenous medication label. All labels produced for parental medications must be initialed by the technician who prepares them. A registered pharmacist is responsible for the final label inspection. If the medication is not used, perhaps because of a discontinued order, it is often can be recycled for use with another patient. After the labels have been applied, the IV preparations are left for the pharmacist to check along with a vial or container of medication that was used to make the IV preparation. When this check has been completed, the IV preparations are loaded onto a cart or delivery vehicle that delivers them to their destinations. In a home health setting, a delivery service may be used to transport the medications to the patient's home. In a nursing unit, all unused IV preparations are collected and returned to the pharmacy for recycling. As long as the IV preparations are within their expiration dates and are kept at proper temperature, they can be used to fill new orders. Once the technician has finished using the hood area, he or she should clean all unused materials and discard any used products. To clean a horizontal flow hood, wipe down the surface with a sterile 70% isopropyl alcohol swab and then allow the surface to air dry. Dispose of all paper products in a trash bin. Dispose of needles, syringes, and vials in a sharps container. Most sharps containers are made of heavy duty plastic. They have a separate lid that can be locked into place on top of the container and a one-way opening in the lid for the disposal of needles and other sharps. Normally, a 7-gallon size is used and is located outside the hood. When cleaning a vertical flow hood, discard needles, syringes, and vials in a small sharps container placed inside the hood area. Wrap all other materials to be discarded into the spill-proof pad and place inside a chemotherapeutic protective bag. This may be discarded in a special hazardous materials bin located outside the hood. All materials used in the BSC, including disposable needles and syringes, must be placed in appropriate sharps disposal containers and discarded as infectious waste. This is located inside the hood area. In February 2016, a proposed set of guidelines known as the United States Pharmacopoeia Chapter 800 was added to deal with hazardous drugs in healthcare settings. Special considerations apply in the preparation of chemotherapeutic agents, both in preparation and in administration. The following two key changes from USP 797 were addressed. One, hazardous drugs must have separate storage and preparation from non-hazardous drugs. Two, USP 800 requires the use of a closed system transfer device for administration of hazardous drugs. This minimizes exposure to nurses and patients receiving the medication. Because because of the risks involved in handling chemotherapy drugs, technicians must be thoroughly trained in chemotherapy and mixture technique to reduce the chances of exposure to hazardous medications, but should be prepared only in a safe environment such as a vertical flow barrier hood or a BSC. Pharmacy technicians should always follow chemotherapy guidelines and should be trained in proper disposal of hazardous substances. Special chemotherapy gowns and gloves are worn to repel any substances that might spill or drip onto the technician during the compounding process. Double gloves are worn for extra protection. Face and eye shields help the technician avoid contamination of the eyes. Masks are worn to prevent inhalation of any dangerous chemicals. When chemotherapeutic agents are compounded, preparation and cleanup must be done slowly and carefully, and the proper documentation should be completed. So 12, figure 12.21 shows BSC staging for hazardous preparation. 12.22 shows special chemotherapy supplies and equipment used in the preparation of a hazardous medication. If a spill occurs in a horizontal flow hood, it may be cleaned using a gauze pad and sterile 70% isopropyl alcohol. The gauze can be discarded in a regular trash bin. Always wear the proper protective equipment for the type of spill to be handled. If a small spill occurs in a vertical flow hood, it should be cleaned with sterile gauze and 70% isopropyl alcohol and discarded inside a marked hazardous bag. If a small spill occurs in a BSC, wipe up the spill with a disinfectant soap paper towel, and then clean the surface with 70% isopropyl alcohol. The outer pair of gloves must be replaced after cleaning up a spill. Dispose of the materials in the appropriate container. For specific information on spill size and cleaning techniques, you should see the policies and procedures binder. Both pharmacists and technicians must be able to show competency in compounding before compounding is permitted. The pharmacist and technician must complete video and written and practical instruction followed by observations, a media field test, and a written examination. Training and testing must be repeated quarterly for all compounding personnel. Although individuals who prepare sterile products must receive training on standards of sterile compounding, those instructions differ depending on the number and type of manipulations performed. Normally, physicians, nurses, and emergency medical technicians prepare only low risk products. Pharmacy technicians and pharmacists must be instructed on all standards if they are to prepare all types of CSPs. Several steps must be accomplished to complete the proper training by viewing instructional videos from the ASHP. Technicians can learn safe handling of compounded sterile preparations. In addition, aseptic technique verification services such as Veltec products provide training packets for various risk levels. Both ASHP and Veltec have compounding manuals that can be used throughout the training period. Valtech includes media field tests and a written examination, in addition to a visual checkoff list for observation of the preparer. Once the preparation is complete, the growth medium is incubated according to set requirements and tested at various times for any abnormal growth. No growth is acceptable for a passing score. These validations must be completed and passed before the technician is permitted to prepare compounded sterile preparations. Personnel who fail any of the tests must repeat instruction and reevaluation. According to USP 797, the following schedule applies to work skills for media field testing at least. New employees must complete 3 tests successfully initially. Box 12.2 talks more about media field tests and what exactly they are. And do you remember these key points?